Hello and welcome to Paincast, Conversations on Pain and Physiotherapy. This podcast is brought to you by the Pain Science Division of the Canadian Physiotherapy Association. I'm Tiffany, the host of Paincast and an executive member of the Pain Science Division. I practice physiotherapy in Toronto. In this episode, I continue to work with one of the students I mentor in the Pain Science Division Student Committee to develop an episode on a topic of interest. I'll pass it on to Steph.
Thanks, Tiffany. I'm Steph, a second-year physiotherapy student from the University of Alberta. Desensitization is a familiar term to many physiotherapists, yet there is very little consensus on what it actually entails. Why is that? What is the difference between desensitization, sensory re-education, braided exposure, and counterstimulation? How do negative pain beliefs and central sensitization affect our treatment approaches? How do we account for psychological and social factors when treating neuropathic pain? We address these questions in part 2 of our chat with Dr. Tara Packham. Before we start, as a reminder, Paincast brings together researchers, clinicians, students, and patients to facilitate discussions, knowledge translation, and critical thinking on topics about pain and physiotherapy. The views expressed in each episode are of individual guests, do not constitute medical advice, and do not represent the views of the Pain Science Division or the Canadian Physiotherapy Association. Enjoy the episode. When you mentioned the importance of the desensitization and the sensory re-education, these might be a few terms that the audience may or may not be familiar with, but I think it's important to give a clear definition just so going forward everyone is on the same page. Could you provide a definition for desensitization or sensory re-education?
I think of desensitization as a strategy to control the input and the responses to those inputs. And that might be by flooding the area with sensation. And I would say desensitization to me implies that we're directly stimulating the painful area. And I think that can be an effective strategy when the pain gate works. I think that is helpful in times when there is more peripheral level sensitization, that there has been sensory change, there may be dysesthesias associated with that, and that we know that flooding the area directly changes the modulation at the spinal level, and the immediate response is to reduce pain. So it has almost an immediate positive response. That's desensitization. If it makes things worse, that is not desensitization. That's not the expected response that we want. Sensory re-education, stimulation on an area of reduced sensation where we are trying to bring it back to that normal. So desensitization implies that there's an elevated response that we're trying to reduce. Sensory re-education to me implies we have a reduced response that we're trying to bring back to a more normal level. And again, it may be directly on the area of reduced sensation, or it may be on an area of reduced sensation that's adjacent to a painful area. And I would say in sensory re-education, we're not directly stimulating a painful spot. And I think that's an important distinction. Counterstimulation is the term that gets used in somatosensory rehab. And that idea is that we are putting comfortable sensory stimulation into an area of normal underlying sensation. So that is not on an area of dysesthesia or on a painful area. It is on a normal area. So we're trying to use a flood of comfortable sensory stimulation that we're putting it into the system to modulate. Hypersensitivity. That is not a well-defined word. If you look at the medical literature and you type hypersensitivity into PubMed, you are going to see stuff about allergy. You are going to see stuff about psychology. You are going to see stuff about physical stimuli. There is just this incredibly broad definition or lack of definition. It's used across a number of different areas. And I think probably what we have traditionally thought about as hypersensitivity probably is also hypersalience. It's the amount of attention that people are paying to it. It probably is about fear of movement or fear of the unknown. And I also think it probably captures sensory differences in processing that were pre-existing. So in folks that are neurodiverse, they don't deal with sensory information the same way And I think that's something that's a whole new area that is just starting to get explored. How does neurodiversity or differences in sensory processing at baseline before an injury, how does that influence recovery and response to intervention? There's some hints that are starting to come. So there's a couple of papers because OTs have looked at this in children for a long time, looking at sensory differences and have validated some sensory profile tools in adults as well. And so there are some OTs who are looking at that in chronic pain and saying, what are we seeing? We asked a question in a survey that I was part of recently looking at CRPS, and the focus was about sleep and having people fill out some questionnaires about their sleep and about quality of life and their CRPS symptoms. And we snuck in a question as whether or not people identified as being neurodiverse. And the rate of response of, yes, I identify as neurodiverse was double that of the normal population. So that was interesting because that wasn't what we were asking. There shouldn't have been a response bias. Based on the question that we were asking, people wouldn't have come to that survey because they thought we were asking about neurodiversity. We just sort of snuck it in. And that was really interesting that it was more than double the sort of average population rate. We think that that might be something that we need to consider. But if you think about that, if I process sensory information differently, does that mean I'm going to respond differently to something like somatosensory rehab? Does that mean I'm going to respond differently to something like graded motor imagery? What is that going to look like? Am I going to respond differently to a desensitization intervention? So I think that might help us to explain. It might be a treatment modifier that we need to be paying some attention to. Or maybe it will be types of sensory processing patterns that people have that actually make them more likely to be successful with some of these things. It's not just necessarily a negative treatment modifier. I think that'll be really interesting to explore.
I like thinking about definitions. I think it's important to have a clear understanding of why are we doing the things that we're doing. One question I do have about desensitization. This is clearly a word that is thrown around a lot in the rehab world. And sometimes I've seen even desensitization protocols. You first use, light brush, and next stage you use a little bit of a rougher texture, and the next stage you use rise, harder rocks. Are there any basis for that type of protocol? And is it just a matter of it works for some people, it doesn't work for some people?
So Isabel Kintal did a systematic review a couple of years ago that I was co-author on, and we looked at in hand rehabilitation, what was the evidence for sensory stimulation, including desensitization type interventions in hand and upper limb rehabilitation. So looking at that, there was not a lot. And in fact, many of the interventions said if they did stimulation and it made people's pain worse, they excluded them. So they were telling us already, giving us that signal that we only think this works if the person doesn't have sensitization at a central level, that their spinal cord isn't able to modulate in a positive way. But I don't think that's how we've applied it historically. I think we've used a one-size-fits-all type approach. So I do think the evidence isn't great. And yes, there are some historical papers that have talked about it and recommended it. But I think maybe it's time for a rethink and time for some better research, because I don't think it's something we need to throw out, but I think we need to be better at identifying what it is we're doing. Because I wonder if some of the effects that we're seeing are actually less about desensitization and more about graded exposure. Maybe they have more of a psychological benefit than they have physiological benefit for people. We don't know that. When I teach therapists about this, I often will say the other thing that I saw in clinic, and I was guilty of sometimes as well, was I would give somebody a bin of a sensory modality and say, I want you to immerse your hand in that and move around and engage with that. And what I would see is I'd look over and they'd be on their phone while they were doing that. And they're not paying attention to it at all. And actually, I think what we need to emphasize, it's the mindful experience of those different textures and different sensory modalities that we're really trying to contrast and compare and really think about the experience of that rather than just flood and think that some kind of magic mechanism is going to happen that's going to improve that without us really taking on the education part. That's my soapbox. I'll jump off now.
You briefly mentioned graded exposure. If you don't mind providing a brief definition so we can understand the differentiation between desensitization, sensory education, and counterstimulation, how that works or doesn't work with one another.
It's another area that we don't have a great definition in. And I would say, on the basis of literature review that we haven't published, but that we presented with Janet Hawley, a CRPS special interest group meeting last summer, we talked about, on the basis of the literature, when we looked at the physiotherapy profession, physiotherapists tend to talk about graded exposure, thinking about graded exercise. So it's graded exposure to movement. Occupational therapists tend to think about it in the lens of graded activity and graded exposure to environments where they're doing those activities. And psychologists tend to think of it as graded exposure to feared activities. So we might be doing all of those things in desensitization. And I think if we're saying, oh, I want you to move your painful hand in the sensory medium, sometimes we would have people work on discriminative tasks. You're being flooded with this experience of having all those little plastic pebbles on your skin, but I want you to discriminate and find the washer and the penny that I've hidden in that bowl of media and pick that out. Now we've got activity, we've got movement and exercise, and we've got mindful discrimination, and we've got exposure to something that is maybe uncomfortable. We may have packed all of that. And so what's the effective ingredient? I don't think we know. And I think that's something that we need to look at. And maybe it's okay. Maybe it is all of those things. But I don't think that we have a good sense, because there really are not controlled trials of this at all. So we don't know, would these people have gotten better anyway? We don't know what's the optimal dose and duration of this type of intervention. What's the optimal grading protocol? Those are experience-based protocols that people have developed and that often have been adopted because they're easy, they make sense, and we see people respond to them. But I think when people don't, that's when we're not always sure what to do next.
You were mentioning some studies that were conducted on desensitization, and one of the exclusion criteria some of the studies have was that the patient would be sensitized by the desensitization exercise. But I think the other exclusion criteria that I found interesting was having negative pain beliefs. Is that correct?
Yeah, absolutely. And that's been in a number of the studies that have been done, is that if people had fear of pain, they excluded them. And so again, in practice, that's going to reduce the number of people that we're going to be able to apply this with, because we know that often people who have persistent pain have developed some negative pain beliefs or may have come to the situation with them already and they've just been reinforced. So we know that happens. And certainly, I think that is stacking the deck a little bit. We're picking the people who are most likely to benefit from our treatment, which is okay, but it still doesn't tell us, is this going to work in that whole other entire group?
I wanted to make sure that I understand this correctly. For desensitization, would central sensitization be contraindicated? And if so, why?
Yeah, generally that's my soapbox. In central sensitization, what we're seeing is probably a change in the modulation of the signals at the spinal level, but also in the descending noxious inhibitory control system. And so I think that if we're putting in these inputs, that we're expecting the output to be positive, that the mechanisms by which that action happens are not working. We're trying to activate the pain gate, but the gate is broken in central sensitization. And so it's not likely to be effective for people, and probably is more likely to be ramping up their symptoms rather than reducing their symptoms. And we know that that's not very helpful building rapport with our clients either. And so having some tools, being able to think about, well, if I see signs of allodynia, if I see summation, or I'm hearing from the person talking, telling me their story, I'm hearing them describe things that I could interpret as being temporal summation and spatial summation, that, I do something here and my whole arm hurts. That's starting to make me think, okay, this person may have other things going on. They're reporting widespread pain. They're talking about headaches. They're talking about GI irritability. They're talking about all of these other things that send up yellow flags for me. Then I'm going to be more thoughtful about thinking about some of those system management approaches initially to say, how do we settle things down so that we can hopefully eventually tackle that more peripheral sensitization.
Speaking of peripheral sensitization, how likely is it for someone with peripheral neuropathic pain to start developing that central sensitization?
So we know there can be a bit of a cascade, that peripheral sensitization can lead to central sensitization, but I don't think it's a given. I think we know that people may have local focal inflammation, and that triggers neuroinflammation. Sort of say, well, yeah, your nerves are bathed in cranky and pro-inflammatory chemicals. And so we know that if we can start to settle some of those things down, that we're changing their movement, we're changing the oxygenation to the tissues by general exercise and activity, and that we're changing even how the person is interacting with their environment. They're getting comfortable stimuli that they can manage. They're relearning and everything is sort of settling down. That's a good sign. Those are the positive pieces. It is also very much about the emotional aspect, because we know that when pain chronifies, that often it's about building connections in the brain connectome with the emotion and memory area. That chronic pain tends to see this proliferation of crosstalk at the level of the brain. There's more communication, and so there's augmentation of the pain signal with emotion and memory valence. And so again, I feel like when people have peripheral sensitization, how do we address that? Are there things that we can be doing in terms of building self-efficacy and making our therapy environment a pleasant place where people actually find joy to come and interact and feel supported and all of those things? Maybe that's just as important as what we're doing in some of our interventions specifically. That we're actually building a supportive environment that's helping to move them towards positive signaling, and that we're not wiring together negative emotion and negative memories and fear and failure and not being able to do things, not meeting their expectations of recovery.
I think it's very important to highlight that even though we're talking about a method of treating neuropathic pain, a somatosensory rehab method, we always have to keep in mind the whole package we're delivering this, considering the psychological and the social aspects of their presentation.
Absolutely. It is the whole person.
Considering that, let's talk a little bit about application of this rehab method, all the considerations that we would want to have. Let's talk about the nervous system. So in terms of treating pain, pain is so intricately related to our nervous system. So the state of our nervous system has a huge influence on how we perceive pain. So in terms of conducting somatosensory rehab, does it always have to be in a state where you're parasympathetic nervous system dominant, calm and rested? Is that the ideal?
Well, I think it is. And I would say that's one of the things that we really need to be thoughtful of moving forward, is to say, make sure that we're identifying, as we're studying something like somatosensory rehab, that we are asking about anxiety, that we are asking about depression, that we know that those may be modifiers of treatment response. But we can also think about, when we're creating a package of education within that, yes, we're delivering some of the sensory aspects, but are there pieces that we should also be building in, that we are building self-efficacy, that we're building confidence, that we're addressing negative emotions and negative beliefs and negative expectations. I think that's part of it. Certainly the trial that I mentioned where we were looking at chemo-induced peripheral neuropathy, it is combining somatosensory rehab with motivational interviewing techniques. So where we're bringing together those two pieces, because we actually think that that's probably the best approach, that just doing one is maybe not the optimal way, given that we know women after breast cancer surgery really struggle with psychological challenges. It would be unethical to not address that at the same time. To say, if we're bringing people in, we actually think this is probably the way that it gets delivered in practice anyway. As practitioners, we're probably not just going to do one thing, we're going to do multiple things. And so saying, yes, it's this complex intervention because we're addressing both pieces at the same time. Sometimes those factorial trials, we might want to do intervention A that's more physically oriented, intervention B that's more psychologically oriented, and then have an A and B, and where we're looking at doing an analysis then that we're saying anybody that got B, whether that was B or A plus B, what's the effect of that? Is that the optimal response? So from a research point of view, there are ways of doing that. There are ways of adding those things in where we can try and interrogate the individual effects. But we really do need to be thoughtful about how are we putting this in the context. And I would argue that we've done lots of clinical trials where it's treatment as usual compared to the new flavor of the month, but we haven't really defined what treatment as usual is. And often treatment is very multifactorial. And we are using our relationship skills as therapists as well as the individual interventions, that we're not just doing TENS, we're doing pain neuroscience education as we're setting up the TENS. And all of those things are harder to capture in rehab. It's not like take the blue pill or the yellow pill.
Yeah, I don't envy your job. Being a researcher is not easy. Now, apart from considering people's psychological or mental conditions, there's also a huge component of pain self-efficacy in pain rehab, where internal locus of control, a sense of mastery, is actually very important. So first of all, why is it that important?
I think often many of our interventions related to pain have behavioral components. And I would say that if we look at behavior change theory, it is about capacity and opportunity and motivation that change behavior, that we need to believe that we have the power to change things. So self-efficacy, and that we expect positive outcomes, that we expect that what we're going to do is going to have a particular effect, that it's possible to see things change, that it's not just that I have the capacity to contribute to that change, but that change is even possible. Across a couple of different theories, self-efficacy theory of behavior change, and really kind of getting into that perceived behavioral control that would be in the theory of planned behavior. That's a lot of theory. But a lot of what we do in pain actually draws on that. And I would say the other piece is we're often building in educational components because we're trying to change people's knowledge, but not just for the sake that they know more. It's because we hope that changing their knowledge is actually going to translate into changing their behaviors, that they'll understand why, and that's going to contribute to their capacity and their motivation, that we're thinking about it from that perspective. So I do think it's critical because when we're talking about a lot of pain interventions, it's not passive. It's not that we're hooking them up to TENS and saying this is the only thing we're going to do. You have to keep coming to see me and I'm going to passively deliver this intervention. We're saying this is about really self-management of a chronic condition, and that we're giving people the tools to do that and to engage that. Because ideally, even if they don't get to a pain score of 0 at the end, we've hopefully given them tools that they're going to be able to manage. And that if they do have life circumstances change and their pain is evoked, that they're going to know how to manage it and bring it back down. That to me is part of really what our objective is. We're saying, yeah, and I would say that's probably not unique to somatosensory rehab. Certainly, you'll see people talk who have used something like graded motor imagery to say, yeah, I was able to do that. And I know that if I stopped doing, but I know that if things flare up, sometimes I have to go back and I have to start using the mirror box again for a little bit. And if I do that for a couple of days, that'll settle things down. Or, you know what, I was progressing through and I had gone from the laterality recognition to the motor imagery, and I was just starting to add in some mirror visual feedback, and then things flared up. So I had to go back and start again with the laterality cards, reintroduce those, but then I kept doing the motor imagery as well, and I was able to then keep progressing back. I think that's part of self-management, where people start to recognize, oh, these are the strategies that work for me, that help me to manage despite my pain. Because the person may not have, particularly in neuropathic pain, maybe their nerve hasn't fully regrown. So maybe it was a partial injury of some axonal tissue, and maybe it is going to be a while before that fully has regrown and there's been full recovery. But we know that there are still some axons in continuity because they didn't have total sensory loss. But it might be something that continues to change biologically for a while.
So we're talking here about maybe almost like change of your relationship with pain, from wanting to get rid of it, no pain, being controlled by it, to now you're manager of pain. What do you find is the most contributing factor for that switch in relationship?
I do think self-efficacy is a big part of it. Another theory, stages of change. I can never say the name, Prochaska's stages of change, trans-theoretical model. So that idea that, am I ready to change? I'm not implying that people don't want to change, but they may not have the resources, the cognitive capacity, the mental space for it. They've been through trauma, or they're dealing with other things that are going on in their life. They may not be at the place where they can start to deal with that. The case that I talked about earlier said life went right for that particular client. There were some positive things in other areas of her life that I think really were contributors to a more positive outlook and supported her being able to get back into her workplace. It wasn't just that her pain had gotten better, but it was also these other things that gave her the confidence to be able to go back and get more involved in those activities. I do think that talking about how do we get people into the parasympathetic space, maybe actually, and I would say this is across interventions for pain, we need to be thoughtful about how are we preparing people to do things like graded motor imagery or pain neuroscience education or somatosensory rehabilitation. Maybe we do need to have people when they have just ridden the bus to the clinic for 20 minutes and their system is revved up. Maybe starting immediately into doing something in the gym is not the best approach. Maybe they would benefit from spending a few minutes doing some deep breathing exercises to calm things down. I think sometimes that's probably the more beneficial effect of when we're using things like heat modalities. They're using the whirlpool or a hot pack or whatever it is. It's actually more that, right? Their nervous system is settling down in that time. And there may be just as much benefit from that, in that we've stopped them from moving. We've put them in a comfortable supported position. Yes, we're delivering heat, but there's that soothing expectation effect related to that. All of those things probably are contributing to the benefit. And it may be less about the extensibility of the muscle tissue.
And then I suppose how we educate them, the wording that we use.
Absolutely. Are we creating recovery expectations? I really love Nick Sullivan at McGill. I heard him give a talk a couple of years ago at the Alberta Pain Society. They did an online session during COVID, and he talked about having recovery thoughts and what can we do to encourage people to have recovery thoughts and have a recovery focus rather than victimization thoughts or thoughts of pain catastrophization. He was the person who developed the pain catastrophizing questionnaire, and I think he is unhappy that the way that that label has been used as a stigmatizing label. And he was saying, how do we keep people focused with those positive expectation for change? Hope is powerful. And I think that people talk about amplifying the placebo effect. That's one way of phrasing it. But I think it really is about saying, how do we orient people towards recovery? How do we give them efficacy expectations that are aligned with improvement and change? And so how we present that is absolutely critical because we are helping to build that and putting that in context for them.
Patients takes our words very seriously, very literally.
Absolutely. And we are creating messages and images for them of what they can expect. So sometimes we're repairing what they've heard in a medical consultation. Then we in rehab spend a couple of weeks actually trying to patch that back because they've heard some very negative, biomedically oriented explanations that may not actually be helpful, that have not oriented the person toward recovery at all.
Absolutely. Well, going into the final 100 meters of the interview, what's your next research question you're looking at?
So continuing to do work on somatosensory rehab, the grant that Janet Hawley and I just submitted is really looking at complex pain. And I'm excited about that, looking at how are we actually thinking about the way we move and how we're interacting with our environment. Maybe looking at things from, I'm not going to show my hand on that, but maybe thinking about how we measure that and how we might start to change that. I think that's really exciting. I'm really excited about starting to use some more of the tools that we have in terms of accelerometers and tracking movement and looking at force plates and all of that. That's an area that's been underutilized. Lots of stuff in athletic rehab, but we haven't looked at it in things like CRPS. We talk about people having altered movement patterns, but we actually don't have really good data on what that looks like. So it's been more very subjective. And so I think that's an exciting area that I'm looking forward to getting into, being able to do a little bit more, have a few more tech tools at my disposal now. So lots more to do.
That's wonderful. That's very exciting. What do you hope to see in the future of neuropathic pain rehab?
Well, I'd like to see that we have some stronger evidence to put behind the choices that we're offering our clients. Because I do think that probably there's not one size fits all. There's not one thing that's going to solve the problem. But can we get better at tailoring our treatments, identifying who's most likely to benefit from a particular treatment? I can recall getting into an argument with an epidemiologist who was looking at systematic review level evidence and saying, well, there's really poor evidence for anything that we're doing for neuropathic pain. Well, okay, but actually probably that means that there were some people that responded really well, some people that had it might have helped them a bit, and some people that it didn't respond, and maybe even a few people that it made worse. So that doesn't mean we should throw out that intervention. It means how do we capture the people that are most likely to have that good benefit and capture the people that are not going to benefit or maybe be made worse and make sure that we don't give them that intervention. That to me is where we need to go as well. Are there things that we can do? And expert clinicians will look at a systematic review like that and say, well, that's ridiculous. I use that intervention and it works with my patients. And that's not just bias. There's probably some bias there. But that's also, in part, an expert clinician who has done some pattern recognition, and they may not be able to articulate it, but they've done some pattern recognition to start to recognize this is the person who's most likely to benefit. And so that's who I'm offering that treatment to anyway. So can we get to that in a systematic way in rehab for neuropathic pain? I hope so.
It's finding a balance between being very literal to the current evidence and also being clinically informed.
Absolutely. Really, evidence-based medicine, when you look, they kind of realize, wait a second, it's about patient preferences and our expert judgment and the evidence, right? It's the combination of those things that really are the sweet spot for identifying what's going to work best for people.
Absolutely, 100%. Okay, any concluding thoughts before we hit the end record button?
My soapbox that I'll say is assess for neuropathic pain. I think sometimes that's something that we assume that there's neuropathic pain because we know there's a nerve injury, but we may not actually measure it. And I think that's another area that we could do better in. So I'll challenge people, if you're starting to think about neuropathic pain, maybe start to assess it more systematically.
Thank you so much for this whole night spending with us talking about this topic. It was very illuminating.
Thank you for listening to part 2 of our discussion with Dr. Tara Packham on neuropathic pain management. If you want to read more on this topic, we've included some articles and links in the show notes. PainCast is a freely available resource for you to advance your knowledge about pain and physiotherapy. We will continue to provide you with top-notch, evidence-based, and practically oriented content. To help more people know about this amazing resource, follow us, rate us, and share our content with your network. You can follow us on Instagram at paincast.psd, where you'll find bite-sized knowledge in 1 to 2 minutes. You can also use the feedback form linked in the show notes to help us improve. Thank you again, and stay tuned for future episodes on pain and physiotherapy.